Right. I think we'll get started. So I just want to state those presentation today, it's really talking more broadly about what I'm doing at UCSF with the Pediatric Epilepsy Clinic, and that includes all kids with epilepsy, and a subset of those kids have PCDH19, but it's also a big, broader group. So I'll try where possible to sort of talk about how much of this is specific and how much of this is broadly applicable to kids with epilepsy. And, you know, I'm a child and adolescent psychiatrist, and I come to this from this understanding that, and as a clinician, you know, I often get patients who come to me saying, yes, there's epilepsy, and, you know, we know what to do when my kid has a seizure, or we know what, you know, how to manage it, but we don't know what to do with the behavioral stuff. And that's often what's getting in the way of quality of life and just day-to-day living. And that's really where I come at this from, is sort of how can we help while we are kind of doing all this really amazing work and figuring out how to treat it in a way so that it's not something you have to manage. But while we're doing that, how do we make things work with the resources that we already might have? So no disclosures. So what I'm going to talk about is how do you approach this, or at least how I think about approaching this from a clinical angle by embedding services. And by that, when I say integrated care, it means so that you're not going to one clinic to see the epilepsy specialist and then going to somewhere else in some other building, in some other clinic to see a mental health provider, if they're even there. But really integrating it all in a way so that it's really patient and family centered, so that the family is in one place and everybody helping take care of the family really goes there. And that's what I mean by integrated care. It's all in one place. And I'll describe the model that I'm trying to develop at UCSF and some very, very preliminary pilot data that we have from that. So, you know, as I was saying, integrated care, there are a lot of different terms when you look at, you know, the good thing is that people at least have been thinking about this for a very, very long time. And it's gone through this evolution of how can we provide clinical services in a way that really works for the families and the patients. And, you know, it started early on with talking about collaborative care, so that the different providers are actually talking to each other. And there were care coordinators who would help sort of facilitate some of that communication. But there were still issues with that in terms of the locations were still different. And then it became co-located care, such that the physicians or the providers were in the same physical location. But integrated care is not only think of three things that's integrated. So the people are integrated, the place is integrated, and how they do work is integrated, so that it's one big workflow of how information on patient care flows. And so it can be anywhere from very minimal to completely integrated, so that it's one medical record, everybody has access to it, everybody knows when the patient is going to be seen or the family is going to present, and it's all at one time. All through the same sort of, you know, payment system, so you're not checking in multiple times, those kinds of things. And that's kind of truly, fully actualized integrated care. When you break it down to how do you do integrated care, there are 4 basic components to it. And the key of this is really there has to be a sort of medical home. So one place that the family goes to and then everybody goes, like that's really core and at the heart of this concept, and that the team owns the care, so everybody's responsible for all elements. It's not really, you know, so you don't get providers saying, well, I can't help you with that, and why don't you ask about this to that person, so that it's the team talks together, and it's really team-based care. And then stepped care, so that, you know, you're getting kind of the level of care you need. It's not a one-size-fits-all. Some people might not need all the services available and others might. So really kind of figuring out what is the level of service this family needs and then meeting that need. And there are different models of how to actually do this. And the 4-quadrant model is one of them. And what the 4-quadrant model is, this is a very kind of busy slide, and I won't expect you to read it, But I would just think of it like on the vertical axis, if you have the complexity of mental health challenges, and then on the horizontal axis, if you have the complexity of the physical health challenges, so in this case, think about it as epilepsy, or, in other cases, it could be some other medical illness, and you create this sort of 2x2 4-quadrant grid, and you kind of at the bottom, you have the low mental health complexity. At the top, you have the high mental health complexity. And then similarly on the left, you have low physical health complexity. On the right, you have high physical health complexity. And you can kind of really look at where the patient is in which quadrant and really create a package of services for that particular quadrant. But that requires us to think about how do we decide who belongs in what quadrant? The program that I'm talking about, the COPE, so this is actually how I've, so in addition to being in the epilepsy clinic, I direct the consult liaison service, which basically provides mental health services for all kids with medical illnesses across the children's hospital. And this is how, I use this to even conceptualize broadly how to help kids within the whole system. And then the COPE program, which is the one in epilepsy, they tend to have the higher behavioral health and high physical complexity. So that's where it belongs. And I'll talk a little bit about COPE and why, while most of the other programs that I run are in the inpatient setting, this is the one outpatient kind of arm of that, because I feel like there's a huge need. So if you look broadly at epilepsy, 30 to 60% of kids have psychiatric comorbidities with a diagnosis of epilepsy. And it's a huge range. If you think of 30 to 60 is nearly double the number, but most more modern studies put it around 50%. And if you have uncontrolled epilepsy or if you have complicated epilepsy, then you're much more likely to be on the 60% end of it. And that, to just put things in perspective, is anywhere from 3 to 9 times more than the general population. So there's a huge burden of mental health issues. And there are other variables that contribute to this. And then if you look at all the different mental health diagnoses or challenges that these patients face, the highest rates are for mood and anxiety disorders, with about a quarter of those who have mental health disorders facing mood disorders. And I think this is different for patients who have PCDH19. And then it's something that, I think I'm interested in figuring out more as we compare and contrast different things. And it was interesting to see from the registry the different things that were coming up. It seemed more of these kind of behavioral externalizing. So we think about mental health in 2 ways: internalizing, which is like mood disorder, anxiety disorder, where you tend to sort of take things in, and externalizing, which is more aggression, agitation, behavior difficulties, ADHD. So those would be 2 big categories. And even though globally with epilepsy, we see more internalizing disorders, I think that there's a difference with the PCDH19 group. We do see more autism features, the intellectual disability. It still remains to be seen if attentional difficulties are truly ADHD, or is that really something different with executive function challenges? And then is anxiety what's driving their externalizing behavior, or is that separate from the externalizing behavior? Because, I often tell parents, like, kids can be like porcupines. They get scared, so they get prickly. And is that what we're seeing, or is it something else? And, with all of this, given the very, very high rates, the problem with care, as usual, is if you look at how many kids with whether or not they have epilepsy, with mental health needs, only about 2/3, so 1/3 receive care. So the majority of the kids with behavioral health diagnosis don't get any care. Of those who do get mental health care, 3 visits is what they get. And not only, having this impacts your behavioral health care, but they're less likely to access physical health care because there are all these challenges to making appointments or going to physician's visits or being in a setting where they understand the challenges of having this comorbidity. So it's a huge issue, and it really impacts, I think, global health, not just mental health. And so because care as usual really does not work, I feel like we really need to be proactive in screening people, so that, you don't wait for the parent or the family with the resources and the voice and the ability to go and get those resources and get the service, or even recognize that, oh, I think something's going on that might be behavioral, so I should get services. And that's why I think it's really important to screen. Also because if we don't screen, they don't receive care. So 1 in 8 kids, unless you screen them, they don't get the care. And there's a huge delay. So even of the ones who get care, it takes 8 to 10 years for them to actually get a diagnosis from the first onset of symptoms. So often by the time I see a kid as a child and adolescent psychiatrist, they've been dealing with this for an average of 8 to 10 years. And either didn't know that this is what was kind of going on with a mental health issue, or didn't really have the right access to services. And so by screening, even if it's negative, we still kind of engage families, I think, and it's an opportunity for education. So that's great. There's no anxiety, depression at this point, but here's what you should look for. Because often, we don't know what it looks like, or, if you talk about parents or family members, they don't often know what to look for in depression, anxiety. Like, what does it look like in a kid? And what does it look like in a kid with epilepsy? When there are all these other, factors to consider, like, are the medications making them really tired and nervous and anxious, or is this depression or anxiety? And how do you separate that out? And that's why I think it's really important to screen. At UCSF, we went through a few cycles of trying a few different tools for screens, and we kind of have landed on this kind of toolkit of screening tools, and it includes a broad range of topics. I am very interested in looking at the psychosocial determinants of health. So, I want to know about the seizure severity and side effects to kind of account for those. Is this medication related or not? But I'm also very interested in how does this affect stigma? How does this affect their quality of life? How is it affecting, it says maternal mood here. My hope would be to really say parent mood. And the reason I put it here is because there's lots of research in other areas in kids with medical illnesses that show that, there are impacts of caring for kids with chronic illnesses that really affect families, and that in turn then also affects the child. It's a bidirectional relationship. And as I'm thinking clinically, I want not only to intervene with the kid, but also like really think of the family as a whole, and how can we make an impact on improving their outcomes. And then the bottom one is the pediatric symptom checklist, which really looks at the mental health screen. It's 35 items. It has parent and youth versions. And I think it's really important because, again, there's a lot of data that shows there's often discordance, especially with teenagers, between their ratings of how they're feeling and the parents, how their parents think they're feeling. Especially with things like depression, anxiety, teenagers don't tend to, there's no one way that the teenager looks when they're anxious and depressed, and they don't share as often. And it's available in many languages. It's been validated in many, many countries. It's been used in integrated care settings, including in epilepsy, and it's publicly available, and there are different cutoff scores. And then once we go through this list, if certain things come up as high, then we go ahead and do more specific scales for the specific subcategories to kind of get a much better sense of how these kids are doing. And then basically from a procedural standpoint, the hope is to screen annually, at least for all the kids in the clinic. And then if somebody has, had a positive anxiety scale, then to follow it up every 3 months to make sure that they're making progress, that the treatment is actually doing what we want it to do. If not, we need to rethink what we're doing. And then these are just more logistics about how we're doing it. So, screening, I often get this question both from kind of providers, but also a very important thing about families. If I'm going to screen, what am I going to do about it, right? Because I don't want to know if somebody is anxiety, depressed, and then not be able to do anything about it. And so it's very, very important to have the other end of it figured out, is once I get these screens, I can figure out their severity of epilepsy, their severity of mental health. Now I have figured out which quadrant they're in. But then what am I going to do once I know which quadrant they're in that 4-quadrant model? And this is where, appropriate interventions are really important. And so this is how it plays out in the quadrant right now, the way we have it. The kids who are in quadrant 1, low behavioral health, low physical health, and really what we're doing is creating this library of resources, which is more websites, educational tools, prevention strategies, certain apps, things that can help you increase resilience, because the flip side of mental illness is mental health, and kind of there's ways in which you can increase, just like, you exercise to keep your physical health up. There are things you can do with your mental health to build up resilience. In quadrant 3, which is still low behavioral health but high physical health, the idea is that they're still followed by their primary epileptologist and the nurse practitioner in that clinic, and then we have kind of regular meetings if needed to discuss cases as they might come up, if minor concerns come up, in which I can, or the psychiatrist or any behavioral health specialist can help the primary providers, the epilepsy providers, really just manage it without necessarily getting involved directly. Up top in quadrant 2 and 4, this is where, I do see the patients more directly because they have a higher behavioral health comorbidity. But the goal with quadrant 2 is to really stabilize and transfer them to a nurse practitioner. I'm really lucky in that I imagine some of you have worked with Nicole, who's great, and she's, a neurology nurse practitioner, but she actually, after we've started working, has gone back and gotten her certification in mental health and psychiatry. So now she has more specific training to work with both mental health and epilepsy, which is really great. And then our social workers are really helpful. The neuropsychological testing is in all the quadrants because that's really kind of case-based, based on what's going on with the kid. And then quadrant 4, which is really kind of there's, really more complicated kids, I tend to see, and if possible, I will stabilize and transfer over to the nurse practitioner. But these are the kids that I tend to follow more longitudinally. And really the model is to stabilize and move down to a lower quadrant. And the reason to do this is, from a realistic standpoint, if I saw everybody, I would see 20 patients and then I'd be done, because if I followed everybody long term, then it wouldn't work. And this is the challenge of sort of the limited mental health resources, which is the reality in our country. And I mean, we are lucky in sort of the big cities and in coastal states, because in the middle of the country, there are places, the entire state, there's 2 child psychiatrists in a state. So these models really take into account the scarcity of resources and are designed to sort of keep the flow going, so that, and this is what I meant by stepped care, so that, the people who need the most intense care get the most intense care for a period of time, with the goal that they're stabilized and will need less intense care over time. All right, so that's the model. And so they have access to these services. Like I said, once you screen them, you need to have access to services. So our team, the nurse practitioner I talked about, we have social workers, neurologist, and the child psychiatrist. We have a neuropsychologist. We're thinking of more things. I know one of the things that's coming on is parent support component, and I know we have our licensed clinical social worker who's going to talk next a little bit more about that, and I'm really excited about that. But really more services, because providing a behaviorist, because I'm seeing more and more kind of behavioral dysregulation, and having a behaviorist who can work with families and having a psychologist would be great. And then, again, this is limited to patients who are within the city, and sometimes the social workers will help us refer out to local providers, but these are more sort of specific treatments that, people might need if they have an anxiety disorder, for example. CBT or cognitive behavioral therapy is really helpful. Parent management training is great for kids with ADHD and other sort of acting out behaviors. And then, if there truly is an autism diagnosis, locally there's the STAR clinic at UCSF, but I know regional centers play a big role in this and kind of assessing and providing services. And And then the last thing, if you're going to, at least I believe, if you're going to provide all these services, what I'm most interested in, what works, what doesn't work, so that we don't keep doing things that don't work. And that's why it's really, really important to assess outcomes. And that's what I'm interested in collecting data on is, are these meds working? Are these therapies working? Is this program working? Or what do we need to change? Because, kind of using the limited resources in unhelpful ways is really criminal in my mind. So this is, again, very limited. We had about 40 patients in the pilot. And this was after a few iterations of different scales that we landed on the 150 questions that I'd shown you. Of the patients so what we did is ran a pilot over a couple of weeks and just collected data on that. And our hope was to see kind of problem solve with this and then roll it out to everybody in the clinic. So we were able to include 46% of the patient that had appointments in that 2-week period. The reason that the other patients were not able to be included was either they were younger than the cutoff for all the scales that we were using, which were 10 years, 8 years old. And then telehealth visits, and in the future we might roll it out to telehealth visits, but just for the purposes of the initial rollout, we were not going to do that. And then others were patients with really severely low functioning, where there was not going to be meaningful data to be collected from this. And so what did we find? Since we were trying to stratify behavioral health and physical health, we found 67% of our patients fell in the high behavioral health category. So, that's I think, both surprising and not surprising. If you ask families, they're like, oh, of course, this is what we're living with. But it's also, if you look at the national numbers in epilepsy, 50 to 60 range. So this is clearly the population that we see. And some of this might be skewed because this is happening at UCSF. So if I did the same thing in a primary care neurology clinic, or a community neurology clinic, those numbers might look somewhat different, but we do end up kind of getting more of the complicated cases. So it might be skewed by that. And then the QALC, there was a huge impact on, so it was half and half for impact on social engagement and ability to socialize, and 42% had physical impairment, so physically impacted from being able to engage. With quality of life, this is, I found it very fascinating as a child psychiatrist. I mean, stigma is second nature for me to think about it, because there's so much stigma against mental health issues. But this stigma is looking simply at the stigma of having epilepsy. And honestly, I was surprised. And then later was like, why was I surprised? But there's a lot of stigma that families and kids deal with. And then there's a lot of physical fatigue. And some of this hopefully we'll be able to figure out, once we look at the medication side effects, and if it correlates with that or not, whether it's, kind of more psychologically driven versus driven by other factors. So the outcomes with the different quadrants that I talked about, the 36 of those patients were in quadrants 2 and 4. 6 I was able to stabilize out of that and move down from quadrant 4 to quadrant 2. Quadrant 3 had 7. So just to remind you, quadrant 3 is high physical health, low behavioral health, and then 2 and 4 is high. 2 is high behavioral, low physical, and 4 is high, so high behavioral, high physical. And then what we saw, and then 7 of those patients I was able to stabilize enough and get to quadrant 1, transfer the care to primary care doctors. And then we saw a lot more externalizing symptoms than internalizing symptoms. And again, this is sort of discordant from the general epilepsy literature where you see more internalizing, so depression, anxiety. And again, I need more numbers to really be able to answer the question, but I was wondering, given the clinic I work in, and because a lot of the patients in that 2-week anyways were Nilika and Joe's patients, and they have a higher concentration of kids with Dravet, and a lot of the kids I see also have intractable epilepsy or getting prepared for surgery or post-surgical patients, and so that might skew the number a little bit, depending on why we're seeing more externalizing. But it's definitely something, it piqued my curiosity when I saw the data from the registry. And then degree of medication responsiveness also impacted the scores, which is, it makes sense that if you're more stable and if you're responsive to medications, you're much less likely to have other problems. And so lessons learned, challenges, like at least here in California, our biggest challenge is just the dearth of resources for mental health and community providers. And if you live in California outside of a big city, then you know what I'm talking about. Because it's really hard to find mental health providers, the funding in the county system, because it's so fragmented and it's county by county, it's really hard to get those resources. And so we've had to rethink. I think initially I had envisioned, of those 36, I've kept 30 patients. Well, 30 stayed and 7 got transferred to the PCP and 6 got to 17 patients. And so I was hoping to keep a lot fewer patients, but I've had to readjust my expectations and rework some of the structure of it. And then hoping that as we bring on more people, whether it's, Ashley, who's going to help with families or psychologists and behavior, so that we can collaborate and innovate and think about this together and more broadly, and hopefully collect more data about, all of this stuff. Is it working or is it not working? And I think that's the end of my talk.
Any questions?
Hi, it's so nice to see you again. So from a neurology clinician perspective, I think this is a beautiful model, but when we are in a neurology clinic trying to deal with seizures, seizure medications, side effects, school letters, a bunch of other things. And it's not just in California, in the entire country. There is so much difficulty to get into a psychiatry clinic. So many times we do end up taking over basically managing autism symptoms, sometimes managing depression, even adding some psychotic and psychotropic medications. What do you think of that? What do you think would help the best in these situations? I have in my clinic so many patients that have been waiting for 6 months to see a psychiatrist, and I'm at Boston Children's, where I have so many resources.
It's a whole different, I think that's a really great question that's multi-layered. And if you're asking me what I think should happen, I would ask you like at what level? Because I think there needs to be policy changes at like the national insurance level, that there should not be mental health carve-outs, right? Because that's, I think, a key problem, is that insurance companies can carve out mental health and farm it out to other subsidiary companies that are, and they have different pots of money. So even if you're bleeding money because of mental health issues, because it doesn't impact the parent insurance company, but they're saving money by not, doing all these medical procedures. So I think we need all of it in one big bucket so that everybody's accountable in a way. So I do think that accountable care organizations, which is different from the insurance side of it, but organizations are reimbursed based on kind of whole patient outcomes, I think is one way to think about that. And if we don't address mental health outcomes, nobody's whole health outcome is going to be good. So that's one answer kind of at the big meta level. At the clinic level, to zoom in and make it granular, what really works is this sort of hybrid of what I have talked, but then also creating sort of a consultation model to the provider, so which I do with some other clinics, where I go there once a month and do sort of these mini talks, or it's like, okay, I'm here, to the epilepsy providers, right? So it could be subspecialty providers who have like an hour a month to to ask about any mental health questions that they have about their patient. Okay, this patient's on this med. This is what's going on? And then I can help consult to them, but also do mini education of like, this is how you can manage this particular mental health issue. This is how you can manage that particular. And so like really expanding everybody's scope is one way that practically we can solve it. Ideally, there would be a child psychiatrist at every clinic, a psychologist in every clinic, but that's my dream. Yeah.
Anyone else? Thank you very much.